Well, I want to get back to our second-line data because I think we've talked about AXIS, and I think that's an important study. There's also a new, recently reported phase 3 study, INTORSECT, which Brian alluded to, which is another head-to-head comparison in this second-line previously treated space. Tom, do you want to walk us through the INTORSECT study and the results?
Sure. So I had the pleasure of presenting this at ESMO this past year. It's also known as the 404 trial. And it was a pure second-line trial in that patients had to have had either intolerance that was protocol-defined or progression on frontline sunitinib. It could eligibility criteria allowed patients to be clear cell or non-clear cell, and nephrectomy status was not important, so they could be nephrectomized or not. And they were randomized in a 1-to-1 fashion, total of 480 patients, to receive either the Sorafenib 400 milligrams twice daily or to receive IV Temsirolimus weekly. The Sorafenib being the VEGF inhibitor that we've spoken about earlier, and then Temsirolimus being the mTOR inhibitor. The primary endpoint of the trial was progression-free survival. Secondary endpoints were overall survival, time on prior Sutent less than or greater than 6 months. And then also we looked at how people with non-clear cell histology did versus those with clear cell. The trial was well balanced. We found that over 98% of patients were 0-1 in ECOG performance status. 80% of patients were clear cell, 20% were non-clear cell. The path reports were not centrally reviewed, however. And about 89% of patients in both arms had nephrectomy. The results, we showed an 8% response rate, RECIST defined in both arms, so equivalent there. Numerically, Temsirolimus had a greater progression-free survival, approximately 4.3 months, versus the Sorafenib at 3.9 months. That was not statistically significant. The primary endpoint of the trial was progression-free survival, so the trial was therefore negative in that regards. Where the surprise was, and a little bit of shake in the RCC community, was the reporting of the secondary endpoint, overall survival. There we saw a statistically significant advantage in favor of the VEGF inhibitor Sorafenib, coming out at about 16.67 months versus the mTOR inhibitor Temsirolimus about 12.3 months. Again, highly statistically significant, fraught with a lot of interpretation, potential biases, but nonetheless a 4.5-month difference in overall survival that's hard to just completely discount. Toxicity is what you would expect differences between mTOR inhibitor and VEGF inhibitor. So when we get back to this discussion about sequencing therapy and what's ideal in second, and what Brian alluded to first, is that as you start collecting these different trial pieces, there's no one perfect trial that answers the question. The preponderance of the evidence, greater than 50% of the evidence, is in favor, in my opinion, of sequential VEGF inhibitors based upon this. And so in my practice, to me, that would be the default in most patients, would be to try to sequence VEGF in them.
Even though your primary endpoint here, progression-free survival, was really, not statistically significant one way or the other.
That's right. But so what we're looking at is we've just reviewed the AXIS trial. Brian's already told you the level of evidence is really in favor of axitinib as a second-line therapy. It's really been studied as a pure second-line option with the greatest PFS, 6.7 months from that trial. Everolimus is certainly there as an option. The trial was more of a dirty second-line and beyond refractory trial. You add to it the issues with survival with this trial, what this trial brings. It makes me feel that there is something to VEGF inhibition, that tumors are VEGF dependent, and there could be some derogatory effect potentially of mTOR inhibition. Now, what is brought up as controversy, people will they'll say, well, what was the additional therapy that patients got? Could that have influenced? And so unfortunately, the way the trial was designed, that data, again, the trial was designed back in 2006, 2007. There wasn't necessarily the need to collect this, but we were able to collect in about 10% of patients, a random 10%. And in that random 10% of patients, there seemed to be a balance between those patients who are on the mTOR inhibitor, Temsirolimus. They went on to receive VEGF inhibitors, and once in a while they got everolimus too. And those people that were on the VEGF got the mTOR inhibitor. So it seemed to be balanced, but again, it was a minority, 10% of the patients. But that's a critique of the result.
Was there a difference in survival in that 10%?
No. So it was well balanced.
So that represented equal survival?
No. It did not influence the results. The results were the same, where we saw a difference in survival between
for the whole population?
Yes.
But for the 10% that you had subsequent therapy
we don't have survival data on that. All we can tell you, because the question is what did the other people get in follow-up to that? And what we can show is that it was balanced. People got equivalent therapies in follow-up.
I
That's
just want
the
to
question.
understand, you're trying to say that 10% is really representative of the other 90%.
No. What I'm telling you is that the critique is that we have no data, and I'm telling you that we have data on 10% of patients.
Okay.
And at least in that 10% of random patients, we show that there was a balance.
There was
That's
a
all
balance.
we can say.
And you don't know the survival of that 10%.
No.
Is that also equal? Or is there a 4.5-month difference in survival in the 10%?
Yeah.
Yeah, we don't know that. We don't know that.
Okay.
It's not been examined.
Yeah.
I mean,
So I-
they
but
know
I-
it, but
yeah.
right, but it's not been examined.
Not
I
been
mean,
examined.
you know, again, I use these data as I think about, you know, how we approach sequencing patients. We have data from a large randomized study, Record 3, that shows VEGF is, in my opinion, superior to mTOR in the frontline setting. We have level 1 evidence that patients live longer if they get second-line VEGF therapy. So to me, the default has to be VEGF to VEGF. Sure, I'm certain there are patients who are more TOR sensitive. We don't know how to identify them. And again, the imperfections of the trial, but it's, you know, PFS gets critiqued a lot, but OS is a hard endpoint, right? So unless we postulate that in those 90% there was some wild imbalance of third-line therapy, or that Temsirolimus prevented people from getting third-line therapy, or something, which we don't really have any reason to believe, because every large trial has showed that subsequent therapy is about 50–60% in both arms.
And this was a U.S. study.
This was an international trial, U.S. and non-U.S.,
But I think that
but European mainly.
the biology of this disease now is in concert with some of the clinical trial results. I mean, whereas before we had this conflict, which was, boy, we have, you know, everolimus or a TOR inhibitor following a VEGF inhibitor, as though the biology somehow changed in that interface. And I think most of us would argue that the biology of what happens in the majority of patients with abnormalities of the von Hippel-Lindau gene is that the downstream effects on angiogenesis persist during the course of their disease, maybe to a greater or lesser extent, maybe to resistance pathways that cause them to come off of one drug and need to go on a different one, but that this disease, clear cell renal cell carcinoma, is predominantly VEGF driven or angiogenesis driven through the mutation or hypermethylation pathway, and that we now have clinical evidence that supports the continued blockade of that pathway offers patients high level evidence of benefit. And you know, as compared with 2005, 2006, that's very consistent with our notion of the biology. And hopefully, as we talk in the next few minutes about where we go from here, it will allow us to continue to evolve the marriage of the biology to the clinical options.
I mean, to me, it's sort of analogous to prostate cancer and hormone therapy. And now with a new generation of prostate agents, they're just, it's, you know, super hormonal therapy. It's androgen annihilation. So it just says the biology is the biology, right? And it doesn't fundamentally change, at least early on. Now, we would argue about third and fourth lines of therapy. I think then other things are happening. But the preponderance of the evidence in early metastatic kidney cancer is that it's VEGF driven. And again, most of our agents are directed towards that, so it kind of naturally fits.
So, you know, Dan, you know, another thing that this data brings up, and it's been questioned, and maybe with some of the recent changes maybe in the way the regulatory agencies are approaching therapy for kidney cancer, is PFS a valid endpoint? So people will now point to this trial, whether, you know, you agree with it or not, but they'll point to it and say, what is it about second line? Why is there an uncoupling now of progression-free survival? We've seen the regulatory agencies, when they've gotten a survival discord, they've questioned drugs. We've seen it with Avastin in breast cancer. So, you know, interesting to what your thoughts would be for that. So
Yeah, no, I think you're absolutely right. And I think particularly when we're getting into some of these second or third line settings, that's where, you know, PFS may be, you know, not as necessarily robust. Even response rates may not be what we'd expect to see in the frontline setting. So I think it's a really important point that, you know, each of these settings, those secondary endpoints of OS need to line up with what we'd expect to see for a PFS result. And when they don't, I mean, to your point and Brian's point, we really, whether we have the data there or not, we got to raise the question, you know, is there an effect there subsequent to treatment that we're not measuring?
And
so
also,
with the challenge with that, though, is the level of evidence that, or the level of information to sort of analyze overall survival, I think, has to really be brought up. I mean, if you don't know what the subsequent therapies are that these individuals receive, and those could be potential confounding factors. if we're concerned about that, I think it's going to be very important for us then to make sure that when these trials are done, that this information is gathered. Because right now, I mean, I'll push back a little bit, you guys. What we have is we have one trial that's suggesting perhaps superior overall survival in a VEGF sequence. We have a number of other studies that sort of demonstrate that people do okay if they receive an mTOR inhibitor. So the question of whether or not there's something clearly happening here with regards to VEGF mTOR versus VEGF, I think needs to be proven, and we don't have that proof. But it's clearly an intriguing, Tom's study is very intriguing. It raises some important questions, which I think we don't have quite the information to answer completely.
But I think, and I couldn't agree more, and I think that what's impingent upon the clinical investigator community is trying to align the endpoints of trials with what the patient would otherwise benefit from. And I've yet to have a patient come in to see me that wants to know what their progression-free survival is going to be. They really want to know exactly how long, whether it's going to affect their quality of life, their quantity of life, and we've used this intermediate endpoint because it's an easy way to, we think, approximate the thing that patients want. That was an okay scenario when we had very few drugs in this space. Not sure that it's an okay scenario as we start to think about novel therapies, which we'll talk about in terms of vaccines or other immunomodulatory agents. And I think imploring our investigator community to be committed to collecting the information with what happens to the subject even after they meet the primary endpoint, if it's PFS, is absolutely critical.
Good points. Good points.
And we're going to have to demand that from the pharma companies that are sponsoring the trials, because as we've seen in recent trials, the majority of the enrollment can be ex-US, ex-European, and I think that data can be very difficult to collect.